Good morning. We are ready to start. I hope everyone's excited. Welcome to Walden Center for Education and Research's second annual conference, Advances in the Treatment of Eating Disorders, Integrating Research with Clinical Practice. My name is Kristen Braun, and I'm the Assistant Vice President of Marketing and Community Relations, and we are thrilled to have all of you in the room today. It's going to be a really exciting day. I've had a chance to preview all the slides, and you're in for a treat. The Walden Center for Education and Research is devoted to improving the quality of life for those who suffer from eating disorders, mood disorders, and obesity. As an organization, we are committed to discovering effective treatments and ultimately decreasing the number of people who suffer from these devastating illnesses. After lunch today, Dr. Stu Komen will speak a little bit more about the great work that Walden Center is currently doing in our communities through its clinical education and prevention programs. So planning for today began almost a year ago. After last year's inaugural conference, we listened to your informative feedback, and we've made some minor tweaks to this year's format in order to deliver a stellar program. We have amazing speakers, Dr. Christina Baker, Dr. Cynthia Bulik, Dr. James Greenblatt, and Dr. Rebecca Peebles, who have each prepared talks that will promote conversation, collaboration, and of course, lots of questions. At registration, you each received a bag, a Let's Talk About It bag. Let's Talk About It is a campaign that was started through Walden Center to just get people feeling comfortable with talking about eating disorders. We also have t-shirts on sale for $20. Clients really love these shirts, so it might be a nice idea to purchase for a client when they're leaving treatment because they have fully recovered. You should have copies of 3 slideshows in your bag. Rebecca Peebles' slideshow will be put out right before she presents later this afternoon. There's also an evaluation form in your bag. You have to fill this out and return at the end of the day, especially if you signed up for CEUs. There will be a red box marked CEU, marked evaluation drop-off, and you can leave it in there. You'll pick up a sheet that will tell you how to download your certificate for CEUs at that point. The only discipline that will be able to pick up certificates today will be LMHCs, LPCs. So licensed mental health counselors, licensed professional counselors. It was a mix-up with the CE organization, so we had to go out separately for LMHCs and LPCs. So you can pick up your certificate today. Everyone else, you'll be able to download it when you go home later today. During the morning and afternoon breaks, there will be drinks and refreshments in the room next to us, the Danielson room, which is where you picked up breakfast. That will also be where you pick up lunch. You can bring your lunch back in here and eat it during the break, 12:30 to 1:30. We encourage you to visit the booths in the hallway. We have some great people joining us today, Walden Behavioral Care, Walden Center booths, a booth from the Multi-Service Eating Disorders Association, Cheryl Kerrigan, and Sue Lewandowski of Eating Disorders Collaborative are all here today. We're also selling books in the Danielson room, so please feel free to browse. The books were recommended by our speakers, or they were written by our speakers, so our speakers would really appreciate if you bought their books. You may have noticed some of you should have a star on your name tag, and if you don't, we apologize, and we'd be happy to place a star on your name tag at a break. This signifies the region where you signed up from, so it might have been your billing address, and maybe that's not where you practice, but we just thought it would be a nice way to meet colleagues in your region. So at every table is a sheet that just sort of signifies what each star means. And if you want more than 1 star, again, just find us at a break. Now the really important question, the one we get the most, where are the restrooms? So rest easy, there are a lot of them here, lots of choices. On this level, there are 2 different restrooms right outside across from the registration table, and then further down the hallway past the Danielson room. The other option is around the corner on either side of this room. You go down the stairs, and there are actually a lot of restrooms down the stairs on the 2nd floor. So if the line is backing up, please maybe go downstairs. At this time, the most important thing, silence your cell phones, pagers if you have them. Make sure your iPads, laptops are silenced as well. If you need Wi-Fi in here, if you're using that to take notes and shopping while listening to presentations, the username is visitor and the password is Bentley, all lowercase letters. If during the day you have any questions or comments, please speak with a member of the Walden staff. We'll always be at the registration table or at the Walden Center or Walden Behavioral Care tables. Now we can officially begin and I can go sit down and eat breakfast. So I'm happy to introduce Dr. Sue Komen to open the conference and welcome our first speaker to the stage.
Great job, Kristen. Thank you. Morning, everybody. What a great morning it is. I see a lot of friends and hopefully new friends. It is a great honor and privilege for me to introduce our first speaker, Dr. Cynthia Bulik. I first met Cindy in the green room at 30 Rockefeller Plaza, waiting for the Dr. Oz show, for our appearance on Dr. Oz. Cindy was the guest expert, and we were there to provide follow-up care for the patient that was being interviewed that day. I was extremely nervous about the 2.5 minutes of airtime on national TV that I was about to encounter. And Cindy and her daughter were extremely concerned about what play they were going to see later that day. And I found out pretty quickly as the show began why, and that's because she was brilliant, and she was a master of the material. And the material was broad. All of the research and all of what we know about what causes eating disorders distilled into practical, helpful advice that I could understand, but even our patient could understand. And I know that for a fact because I talked with our patient later and she remembered certain things that Cindy had said to her that day, which was really hard because she was in the midst of a terrible eating disorder and on national TV. So the fact that she remembered anything was amazing. So let me give you the official statistics here on Dr. Cynthia M. Bulik, Distinguished Professor of Eating Disorders in the Department of Psychiatry and the School of Medicine at the University of North Carolina at Chapel Hill. She's a Tar Heel, what can I say? Where she is also Professor of Nutrition in the Gilling School of Global Public Health, Director of Research at the UNC Center of Excellence for Eating Disorders, and co-director of UNC Center for Psychiatric Genomics, which is going to be a very important thing. She is also professor in the Department of Medical Epidemiology and Biostatistics at the Karolinska Institute in Stockholm, Sweden. She has published over 470 papers and chapters on eating disorders and is author of 6 books, including The Woman in the Mirror and Midlife Eating Disorders, Your Journey to Recovery. I'm a personal fan of Crave. You should check that one out too. She is passionate about translating science for the public and has appeared on many national shows, including The Today Show, Good Morning America, CBS This Morning, Katie, Dr. Oz, and Dr. Phil. Her works have been featured in the New York Times, Washington Post, USA Today, Newsweek, and Time. Dr. Bulik holds the first endowed professorship in eating disorders in the United States. Ladies and gentlemen, Dr. Cindy Bulik, certainly one of the preeminent scientists in the field of eating disorders today.
Let's see, is this working yet? Excellent. Stu, thank you so much for such a lovely introduction. It's great to be here today. Thanks for having me. And I'm hoping that over the next hour and a half-ish, we can turn this into a conversation and not just a presentation. And yesterday I had the honor of talking to some of the Walden folk about some of the genetic research that I'm doing. Today I'm going to switch hats and I'm going to talk much more about some of the new clinical treatments that we've been developing at UNC. And so today I'm going to start off talking about our treatment for anorexia called UCAN, or Uniting Couples in the Treatment of Anorexia Nervosa. And that'll probably take up maybe 2/3 of the talk because we have more information on that. And then I'm going to roll into our newest treatment. So we've taken UCAN and we've adapted it for the treatment of couples in which one person has binge eating disorder. So we'll talk a little bit about where that's going. The lovely people who have funded this research have been the National Institute of Mental Health and the Global Foundation for Eating Disorders. And in terms of disclosures, I'm a consultant for Shire Pharmaceuticals, and I write books for Pearson and for Walker Books or Bloomsbury. And my kids are really excited about the Walker book Bloomsbury part because they publish Harry Potter. So they think it's kind of cool that mom has the same publisher. Little do they know what a difference there is. So these are my partners in crime. Dawn Baucom and Jen Kirby are absolutely phenomenal couple therapists. Dawn Baucom really is the father of cognitive behavioral couples therapy. I have to put them up here front and center because I was not a couple therapist. So I'm an adolescent psychologist. I was trained in family therapy, the old style, and I have really learned couple therapy through my association with them. In fact, the idea for this whole couple-based treatment came when I was interviewing for this job in North Carolina. And Dawn was on the selection committee. And we sat down and we're in his office. It was one of those beautiful North Carolina days where the sky was blue and everything was blooming. And I was like, I might need to come down and look at this job. But he and I just started talking, and he was like, do these people with eating disorders, are they in relationships? Do they have partners? What do you do with their partners when they come in for treatment? And I was like, oh, because at that point in time, we weren't doing a whole lot for the partners of our patients. And so the sparks just started flying in that room, and lo and behold, 5 years later, when I got to UNC, he was the first person I called up, and we started developing this intervention to really do a much better job, including the partners in treatment. So what I'm going to do today is I'm going to talk about just an overview and the role, that's not working, and the role of the partner in treatment. I'll talk about the different phases of UCAN, and then I'll roll into the formative work that we've been doing for Unite and how we actually do Unite treatment. And I'll introduce the one couple. This is a couple. We'll hear a video of them talking about their experience with UCAN. This is a really wonderful couple who have agreed to have their faces and their voices plastered over all of these workshops. And interestingly, they're both nurses, and he lived with her through several hospitalizations of anorexia nervosa and severe life-threatening illness, and had only come to his attention that this was anorexia when his boss actually said, we really need to talk about your wife. I think there's something wrong that needs to be addressed. And they've just been champions for UCAN. So here is, now I tried to make this slide get hidden and it didn't. I'm not going to go through the diagnostic criteria because you all know them. But I am going to talk about the fact that anorexia nervosa exists in a social context. We know that anorexia affects interpersonal relationships. We see that every day in our clinical work. We also know that the arrow goes in the other direction. So interpersonal relationships very much affect anorexia nervosa. And what we're doing in UCAN is very much looking at both of these arrows. How does the eating disorders affect your interpersonal relationships, and how do your interpersonal relationships affect anorexia nervosa? So we did a study in New Zealand years ago where we looked at what the most important thing was in recovery in our patients. And it wasn't their medication, it wasn't their inpatient hospitalization. What they endorsed most of the time was interpersonal relationships. Now that relationship wasn't necessarily with their partner, but it was something on the interpersonal level. There's something about that interpersonal connection and the long-term interpersonal connection that is critical to recovery from anorexia. Now, what we know about the treatment of the evidence base for the treatment of anorexia nervosa in adults is that it is weak. I think we're getting somewhere with children. I think family-based therapy has really moved us into a new phase of having at least one tool that is effective for at least a portion of children with anorexia nervosa. But for adults, our database is much less impressive. And what we need, and what we've said all along, is that we need to find developmentally appropriate interventions that leverage the power of the family or the partnership in the treatment of adults with anorexia nervosa. And that's how Unite was developed. So when we do, and anyhow, then couple-based approaches are what emerged. So when we do cognitive behavioral couples therapy, it is very much focused on the here and now. This is not a therapy where we're having people dig deep back into their relationship to find out what the causal factors were in the development of anorexia nervosa. It is a here and now therapy, and we focus on teaching communication skills. So a large part of what you're going to hear about today is just getting the couple to be able to have conversations about anorexia nervosa. And I thought of that when I saw about what the little theme in your little let's talk about it things are. That's exactly what we're doing it. We are getting them to talk about it in ways that they often never have before. It involves changing specific behaviors, so we do look at the behaviors that are central to anorexia. It involves attending to cognitions. I think I just got volumed. Better? Okay, good. Attending to cognitions, but also very much addressing emotions. And this becomes particularly interesting when we look at the nature of the partners that our patients have brought into the relationships with them. And this is interesting, and it's a question that a lot of my couple therapy colleagues asked when they saw how severely ill the patients were. They said, who are these people who are in long-term partnerships with people with anorexia? What makes them stick? What are the factors that keep them in a relationship with someone who is so ill? And that's something that we're continuing to address because it is a really fascinating question. And really, the truth is we're seeing people who are really dedicated and really in love with these folks and struggling with how to deal with the anorexia. So this is our manual. It's unpublished currently, called Uniting Couples in the Treatment of Anorexia Nervosa. And right now, we're actually working on developing a web-based dissemination platform so we can sort of disseminate UCAN and supervise therapists as they learn how to do couple therapy via the web. So hopefully that's going to be coming out soon. What we've done in terms of UCAN is it is not a standalone treatment. So we have not developed this, so now I think I'm getting feedback. So we have not developed this so that it's the only intervention that people get, although it's something we're looking at. Is it possible to actually just do couple therapy to treat anorexia? I would probably say that no matter what, we're going to have the medical management piece in there. But we're going to look at that, and we're also going to look at multi-couple interventions, where instead of just doing one-on-one with a therapist and the couple, we might bring several couples in together. Because we found in some of our just multi-family groups that these couples really benefit from being in the room with each other. So there might be some differences down the line that we're going to look at. But right now, it's delivered in the context of individual therapy for the patient, medical management for the patient, and dietary counseling with a dietitian. Now, what's really interesting is we started out doing individual dietary counseling just with the patient, but then we found out that the partners really wanted to be involved with that too. Not just so that they understood what the patient was getting, but so many of them had their own issues with weight and with nutrition. So this ended up being built out to be much more comprehensive and much more couple-focused than we had initially thought when we developed the intervention. So this is just the way that treatment flows. I'll walk you through it in this overview way, and then we'll unpack it piece by piece. So the first part is an introduction and a relationship assessment. As you get to know the patients, you do want to know something about their history. So we do go to figure out, what was that sweet spot in the beginning of their relationship that actually brought them together? Because so many of them have suffered so much as a couple that starts getting shadowed over, and they start losing perspective on what it was that brought them together in the first place. So it's really going back a little bit, finding out what the foundation of the relationship is, so that you as a therapist know where the sweet spots are, so as the therapy unfolds, you can go back in there and maybe draw on whatever those initial positive relationship things were. But we also try really hard then to understand anorexia nervosa in the couple's context. I want to know how the disorder lives in the couple. How does it live in the house? How does it live at work? How does it live with kids? How does it live in terms of their relationship? We then really step back from the eating disorder, because from our perspective, you can't actually do couple therapy on hot topics if the patients don't know how to communicate. So we step back from hot button issues. We focus on more basic things like, the kids' soccer, or are they going to get a dog, or things that have nothing to do with the eating disorder when we teach them the basic communication skills, working as a team in the recovery process. And that is the focus of the treatment. It's like we want to bring you, the partner, in to help work with the patient toward recovery from anorexia nervosa. It's a team-building process, and it's so that the patient doesn't feel alone in recovering from this illness. So the two core things that we do, fundamental to the entire treatment, are sharing thoughts and feelings and decision-making. And most importantly, recognizing the difference between those two. So there are times, and I'll go over this a million times today, when the only goal for the patient and the partner are to share thoughts and feelings. And if they start getting into decision-making territory, and it is usually, if it's a heterosexual partner, it's usually the male who starts going into decision-making mode, we need to actively put the brakes on and say, we're just sharing thoughts and feelings now. And making a distinction between what your goal as a couple is, be that sharing thoughts and feelings or decision-making, is the most important step toward effective communication. And then we actually start getting into, once we feel like they have their basis in communication skills, we can start getting into the anorexia-related topics. So we talk about addressing common anorexia challenges as a couple, very basic things such as eating together at home, and then things that are often very complicated, namely eating with others. And that can include things like just going out for a meal with another couple. It can be, and this is always an issue, holiday meals. So going back home for whatever your big holiday meal is that involves lots of family members and lots of food, which can be incredibly anxiety-provoking for our patients. And then, and part of me thinks it would probably be best for us not even to put this in their booklet so that they know what's coming, is the body image and sexuality issue. This is so difficult for so many of our couples, but yet such a critical piece for rebuilding their relationship. So we're talking about body image and couples communication and physical affection and sexuality. The really important thing about this module is that it's entirely flexible depending on where the couple is. For some of our couples, this ends up being 4 sessions just about being able to hold hands again. Because they have just completely lost physical contact. For other couples, it really is getting in there and talking about how to reinvigorate their sexual relationship. And it's that kind of flexibility that really makes UCAN an effective intervention. And then finally, the last phase is recovery, preventing relapse, and treatment termination. We talk about what to expect from recovery, dealing with slips and relapses as a couple. And that's not just slips and relapses of the eating disorder, it's also slips and relapses in their relationship. So if they start falling back into old, unhealthy communication patterns, it's how can we get you back on the horse and use these skills that you learned in UCAN again. And then wrapping up UCAN and moving forward. And now the other thing that we really like about this, because manualized interventions can be kind of like a little bit over rigorous sometimes, we've built in a lot of flex sessions. So different couples need different amounts of all of these sort of areas. So you can pop flex session in there wherever you need. Like if some of them, we had this one couple who had been married for, I think 14 years, and they had never eaten dinner together in their home. So he would eat in the kitchen all the time, and she would take, and this is a really kind of odd behavior, but she would take a jar of olives and go up to her bedroom and eat alone. 14 years this happened. Never did they have a meal together. If we hadn't asked about that, about what was actually happening, we would never have known that this guy also had a disorder. He had a hoarding disorder. And the kitchen was so cluttered that there was a pathway that went to one chair at this little table, and there was only room for one person to eat there. And so in some ways, his disorder was perfectly complicit in maintaining her anorexia. But if we hadn't talked about how do you guys actually eat together, such a simple question, but if you don't ask it, there's so much you don't find out. So, we actually had to then get this guy into treatment for his hoarding problem. We had to get the kitchen cleaned out. We had to create it so that, they actually could eat together and they needed a lot more sessions here than we had ever imagined. So we put a lot of flex sessions up there just to get them in a situation where they could have a meal together. And I think the other thing that I'll say now, and we don't do, but I wish we did, and that is a home visit. Because I used to do OCD treatment as well. And when I did OCD treatment, I went into people's house to see, what is going on here, especially when you're treating hoarding. You have to see what's going on. But until you start asking detailed questions about how the house is set up and how things are organized, you have no idea, and you can make an intervention that is impossible for them to do. Our couple that you're going to hear, we talked about having family meals. They had 2 little boys. And it's like, well, you guys really need to sit down and have a family meal. They didn't have a table. They did not have a table in their house. So we were telling them to do this thing that they couldn't do. They all had little TV trays. And they would just sit in front of the TV at different times watching, eating TV meals or whatever. So again, a big intervention was buying a table. And that's not something you learn in graduate school, So it's really simple stuff, but it's really important. All right, so let's go through phase 1 and just talk about how that goes. So phase 1 is very much creating a foundation for later work. We do that in-depth assessment and just get the opportunity for the therapist to really get to know the couple. As a therapist, it's very important to do a couple things. You need to make sure that you are equally aligned with both partners. If you're a male therapist and you happen to be very skilled, you have to be careful balancing one really important thing. If the female patient sees you as being more warm and more empathic and more able to talk about your feelings than her partner is, all of a sudden you start getting idealized as that male therapist. And you have to be very careful about that. If you're an eating disorders therapist who is trained to do couple therapy, you have to try really hard not to do individual therapy. Because you start, and we've seen this in the people that we've trained, they get pulled into doing individual therapy with the patient rather than really focusing on doing the couple therapy. So I still think the best people to do this treatment are eating disorders therapists who become trained as couple therapists. It's been a lot harder for our couple therapists to step in and learn everything they need to learn about eating disorders. So all of you eating disorders therapists in the room are in a good position to actually upskill in couple therapy to be able to do this kind of intervention. But it's not easy, just be warned. In fact, Jen Kirby, who was a couple therapist and learned about eating disorders, when we did our first couple, Dawn and I both co-supervised her, and we listened to every single session, and we were outside the sessions when she was done, and there were a couple times where she just walked into the supervision room and she just laid down on the floor. And she was like, I am beat. And it's interesting because Dawn and Jen say, and they've done couple therapy for OCD, for depression, for schizophrenia, for breast cancer, they say that this is the most challenging couple therapy that they've ever been involved with. And I think those of us who work with eating disorders, that comes as no surprise. We love the challenge. But for them, it was an eye-opener about just how difficult it can be. So we do psychoeducation about anorexia for both partners. And I continue to be struck by how little both the patients and the partners know about anorexia nervosa. There is still this pervasive myth out there that these are disorders of choice. They know nothing about the underlying biology. They're always surprised about the fact that there's a genetic component to these disorders. But all of these pieces of information get transferred very early so that we're all on the same page, understanding exactly what this illness is, and also helping the partners to understand why recovery is so difficult. So we lay out there right from the very beginning that the patient is fighting an uphill battle against her or his biology, and that our job is to assist them with that. And making sure that we have that biology front and center really helps with understanding. Because if they're coming in thinking this is a disorder of choice and why can't she just eat or why can't he just eat, then we're not on the same page. So the fundamental psychoeducation is actually really important to make sure that the therapist and the couple and the patient are thinking about the disorders in the same way. And then we roll into this improving communication skills for the couple, focusing on emotional expressiveness and decision making. And we will go through each of these step by step now. So in terms of the couple's experience of anorexia nervosa, we want to know the patient's past and current experience of the disorder and the partner's experience of the anorexia nervosa and the symptoms. We want to know how the couple interacts around anorexia and whether there's been prior treatments for anorexia and any couple therapy more broadly. So I'll stop there before I talk about the next piece. So one of the big questions that arises in couples is, did the eating disorder come before or after the relationship? So as you can well imagine, partners feel really differently in terms of how this unrolls. And I'll give you a couple scenarios. So one scenario is that the patient has an eating disorder, gets in a relationship with the partner, says they're recovered, the eating disorder goes underground, and then at some point in time, the partner discovers that the patient really isn't recovered from the eating disorder at all. That this has been going on for a period of time while they've been in a relationship and they haven't been communicating about it. One of the audio tapes that I wanted to play, but the acoustics in the room don't work very well, is exactly this situation. And this couple, young couple, had been together for several years, had backpacked all through Australasia together, and there was one day he was home sick while she was at work, and he was looking for his earphones for his iPhone. And he opened up the drawer next to her bed. And in the drawer next to her bed, it was just filled with food wrappers and leftover food and crumbs and all sorts of things like that. She had told him 5 years previously that she was completely recovered from bulimia. And this is a classic how not to do it situation, but he left a note on the dining room table that said, "You lied." And then he left and didn't come home. She comes back from work, sees this note on the table, and it leads to just a huge fight between the two of them. He felt completely betrayed because she didn't feel comfortable telling him that she had been suffering the whole time. The whole time they were backpacking in Australasia, she was suffering severely from bulimia and didn't tell him. And obviously we had a lot of work to do to get over that particularly poor moment of communication, but that's just one scenario that can happen. Another one that really worries partners, if the eating disorder happened after their relationship, is what did I do to cause this? They immediately jump in and think that they're somehow a causal factor in the development of the eating disorder. And you have to spend a lot of time really talking about this being a multifactorial problem, there being lots of things. Of course, relationships influence the onset of disorders and the course of disorders, but there are so many other things. So being attentive and dealing with any guilt is really important as you're empathizing with partners in that situation. The other thing that we spend a lot of time on is the expectation of the treatment process and what recovery is going to look like. Now, this is a little anecdotal, but it's kind of interesting. So a lot of our partners are engineers or computer science type people, which is kind of interesting. And you have to wonder if there's some sort of assortative mating on the sort of obsessionality dimension. And I'm really serious about this. But what we see in them is a desire for a very linear recovery process. They want this to come down to an equation, a nice, predictable equation. If we do this, this will happen. If we do this, this will happen. And each week, recovery will be closer, and it'll all be good, and I can predict this, and life is good. We really need to work with them to feel comfortable with the nonlinearity of recovery. Because we see so many 2 steps forward, 1 step back, occasionally 4 steps back, and it's not something that is easily predictable. And is really working with them to increase their comfort about the non-predictability and the nonlinearity of recovery that allows them to be able to continue to support their partner when they do backslide. So, right out in the beginning, we let people know, because they'll come in and they'll say that their expectations are really unrealistic and really lofty. And they'll say, finally, I'm involved with treatment and I'm going to be able to do this, and having me in the room is really going to change things. And yeah, it makes it better and it improves outcome, but it's not magic, and it's not linear. So the other thing you have to do in the beginning is really continue to do a broad psychiatric assessment, both of the patient and of the partner. So as we know, in eating disorders, we see lots of comorbid mood disorders, substance use disorders, and self-harm. And again, I'm going to take a little pause and say that that self-harm piece can be incredibly difficult when that comes out in a couple therapy, because this is something that's often kept quite quiet. And one of the rules of couple therapy is we don't have secrets and we don't keep secrets. So the couple therapy is never in a situation where the therapist knows that there's self-harm going on, but that's not being talked about in the room. So we laid that rule out in the very beginning, that there is no secret keeping, because that is the best way to destroy a couple therapy, by keeping secrets. But we have had plenty of patients who do self-harm. Their partner knew nothing about it. And just watching that unravel in the room is an incredibly emotional situation. And especially if they're not having intimate relations, they don't see each other's bodies. So they're not aware of some of the damage that's being done. And in terms of so that's the comorbidity. In terms of the quality and nature of the couple's relationship, we're looking at their relationship history. And I want an intimacy trajectory. So I want to know how things were from the very beginning and how things changed in relation to the eating disorder. And you see every possible trajectory. You see some people who had sort of like wild sex in the beginning of their relationship, and then the eating disorder took hold, and then they gradually moved apart. You see some people who really have had no intimacy whatsoever throughout their relationship, and that was okay. But now they might be a little bit interested in sort of like reinvigorating it. And then you see people who are at different developmental stages who the eating disorder is overlaid with sort of perimenopausal changes. And then you have to start sorting out how much of this is the eating disorder and how much of this is hormonal and related to things that are happening at that stage of life. So again, and I realize I'm saying this over and over, but flexibility is the key, because these couples vary so much in their presentation. We want to know what their communication patterns are, and we want to know their approach to conflict, conflict resolution, and physical aggression. So physical aggression, this is an interesting one. And I'm going to start with heterosexual couples, because I think most of the time when we think about violence in a relationship, we think about male on female violence. In our patients, when the patient is a woman, it's often in the other direction. And if you don't ask about that, you're going to miss it. So in much the same way that in family therapy, we sometimes see aggression in kids who are being refed and go through those horrible periods where they're just absolutely irritable, angry, frustrated, and often violent toward their parents, we see the same thing in anorexia nervosa. And there are lots of situations that we've come across where we see our patients having been violent toward the men. And the guys often take it, and they're often a little ashamed to talk about it, because it's sort of emasculating in that sense. But still, if you do your usual workup, make sure, well, first off, always do your usual workup. Whenever you're working with a couple, you have to ask about physical aggression, but make sure you ask about both directions. All right, a little bit more about psychoeducation, and then I'm going to get you guys talking a little bit. So I talked about this a little bit before, talking about different anorexia symptoms and features. And I will throw one in there that should be in your discussion all the time if it's not already. And that is the role that the internet has in anorexia nervosa. And I think we assess so many eating disorder behaviors, but we don't routinely assess how the internet plays into their disorder. So a lot of our couples, the partners have discovered the patient somehow doing some pro-ana related website. They had no idea that pro-ana websites existed. Their partners start becoming less interested in spending time with them in the evening, and they're off with their computer. And then when they look at the history, they say all these really upsetting sites that they've been to. And this is something that just has routinely blown the partner's mind because they just don't understand how these websites can exist and how the patients can spend so much time looking at them. And so this ends up being something that when we talk about how we can get the partners to assist, that monitoring their internet use sometimes becomes part of the couple task. How can you make sure that they don't slip back into really this obsession with pro-ana websites? We talked about genetics, we talked about sociocultural factors, and one of the things that I spend a lot of time talking with couples about is the role of anxiety in eating disorders. And I'm going to take a moment here to talk about this because this is my personal theory about why people develop anorexia nervosa, and we're trying to understand the biology behind it. So when most of us backtrack, what I tell partners is that their experience of hunger cannot be generalized to the patient's experience of hunger. For most of us, hunger is really unpleasant, and it makes us nasty people. We get scratchy, we get irritable, we get headaches. It is not a pleasant state. For people who are vulnerable to anorexia nervosa or do have anorexia nervosa, hunger is a positive state. At baseline, they feel scratchy and irritable and miserable, and starvation is anxiolytic for them. So part of what our job and the partner's job is to help figure out a way to help the patients deal with their anxiety that is as effective as starvation, but is not starvation related. And that's tough because starvation works so well. And we all know that when we refeed our patients, they get really anxious. And that's because we're removing the one biological factor, which is negative energy balance, that actually works for them biologically to calm that baseline anxiety that they all have, or many of them have. And that's tough for our partners to understand. But we keep coming back to it and help them understand that, if they're away all day and the patient skipped lunch and they're angry about that they're probably dealing with something that made them skip that meal that helped reduce their anxiety. And then we just go through was there a question? Yeah.
Don't you find when you go through the refeeding process that the brain changes, it adapts?
Yeah. Question is, when you go through the refeeding process, does the brain adapt to that response to starvation? My answer to that is yes and no. I think it absolutely does. You adapt, especially with slower, maybe this is anecdotal, but with not real rapid refeeding. But it remains a vulnerability. So what I always tell people is after recovery, stay away from negative energy balance. And it is no different than someone who's been a smoker who might walk past a building during coffee break time and gets a waft of a cigarette, and it's like, wow. And it just like lights up that dopamine, and they're like, oh my God, I remember what it was like to inhale that cigarette. The same thing can happen with someone who has a history of anorexia nervosa who finds her or himself in negative energy balance. They can feel that calming feeling again, and it has a lure to it, especially if it's in a time of stress. So I always tell people for the rest of your life, really watch out for periods of negative energy balance because they're dangerous for you. All right, now you're going to do some work. Okay, so a couple therapist can learn so much from just the body language of the couple when they come in the room. Where do they sit? Do they touch each other? Do they move their chairs to be farther apart? You're constantly using your powers of observation to diagnose not just the illness, but the relationship. So we're going to look at these guys first. So tell me, raise your hand, I'll call on you so we're not all yelling out, what you see in this picture in terms of their body language. Anybody? Yeah.
There's the classic protective stance.
All right, so we've got a classic protective stance in her. Something else.
He looks receptive.
So he looks receptive. Anybody else have an adjective for him? A little angry. So we got some receptive, some angry. Where are her eyes? She's looking down. Where are his? Right, looking at her. So you're always drawing the lines. You're always drawing lines saying, where are her eyes going? Where are his eyes going? And you want to see if they're crossing and if they're looking at each other. And your goal as a couple therapist is to try to get rid of this and to try to get more of that going on. Such a simple thing to do, but you have to pay attention to it.
Also, even though he's looking at her, he's actually slightly turned away from her.
You're right. So he's looking at her. He's given two messages. So his eyes are that way, but his body is that way. So there's a little complex communication going on there. Yep, what else? Yeah.
There's a little defiance in the way that she's pulling her
Lower body and what? What other body part down there? Her legs. They're planted.
That's what I'm saying, because usually if it's more protected, the legs are crossed, they're tilted more over.
Yeah.
She's like very...
Yeah. There's no crossing legs. There's no relaxation. She is planted for battle. And that's what you see. Anything else on them? Distance. They're not really cuddling in this picture by any stretch of the imagination. What's the therapist doing? What do you see him doing? Anybody? Yeah. Yeah. Go ahead. He's got his hands on his mouth, which is kind of weird if you think about it. It's like, is he trying to hold something back, or what's going on? I don't know. Yeah. Okay, contrast. What do you see with these little guys up here? They're engaged. They're mirroring. Very attentive to each other. They're leaning in, exactly. So they're not planted, they're not pulling out, they're leaning in. What else do you see actually about their mirroring? There's so much mirroring in here. They're in exactly the same position. They're holding the cup the same way. You know, I mean, they're just completely in tune. And if you drew your lines with their eyes, they're looking right at each other. They're lasering each other with their eyes. So you know, this is like complete contrast to these guys who are not in tune, and these folks are on exactly the same level. They even have like similar sweaters on, which is quite cute. I remember those days, yeah. So part of the guidelines that we use for sharing thoughts and feelings, and imagine that first couple or the young couple up in the corner when we think about effective sharing thoughts and feelings, because my guess is that those guys are really good at it. So what you need to do is you need to state your views subjectively. So we actually have hats. I mean, not real hats, but we have imaginary hats, because one thing that these couples do a very bad job at is making sure that one person is the speaker and one person is the listener. And as a couple therapist, you really do have to traffic cop this a lot. And you know, you say, you are the speaker now, you are the one who is sharing your thoughts and feelings, and your job is to listen. So what you get the speaker to do is to share views subjectively, and make sure that you express your emotions, not just ideas. So from the very beginning, we're trying to ensure that they're infusing whatever their thoughts are with whatever the emotional baggage that is encapsulating it is. It is thoughts and feelings all the time. And typically, as you all know, the thoughts flow more readily, and the feelings, it's a little bit more tough. So we really have to work hard to pull the emotions out. When expressing concerns, include any positive feelings you have about the person or the situation. So the tendency is to blame and to throw arrows and to just get into fighting stance, like we saw that woman in the bottom left-hand corner. And just being able to soften your sharing thoughts and feelings by saying something like, I acknowledge that dealing with anorexia has been really hard for you. My current feelings are blank. that little bit just opens a door for the communication between the partners and gets them away from that fighting stance. And we want to get them away from a fighting stance as much as possible. We want them to make their statement as specific as possible. We teach this in small chunks. We don't want them to deal with huge global issues that are unresolvable because they don't have the skills to deal with it. And that's just not healthy for a couple to deal anyhow. And we tell them to speak in paragraphs. So we see two patterns. One is we see these one-word utterances that don't really help with sharing thoughts and feelings at all. And the other pattern we see is sort of like stream of consciousness. So we get people to try to share their thoughts and feelings, and they just go on and on and on, and there's no punctuation, and there are no paragraphs, and there are no chapter headings, and it just keeps going. And when the way you do this is the patient or the partner, whoever the speaker is, shares this little bolus of thoughts and feelings. And then we take a break, and then we have whoever the listener was reflect back. What did you hear? What did you hear her say? What did you hear him say? The problem is, if you don't have a paragraph, it's completely impossible to reflect back what the person said. So a lot of it is really teaching people how to encapsulate their information in a way that the listener can actually hear, understand, and accurately reflect back. And that's why paragraphs are so important. And then the last piece is something that's important for every relationship, is expressing your feelings and thoughts with tact and timing. Most of us are not naturally adept at timing. If you survey any couple, regardless of whether someone in the couple has psychopathology, they will really hope that their partner would develop better timing. And I don't quite know why that is, but especially with people we love, we tend to not use our knowledge of timing as well. I think we think strategically in other communications in our life, like in the workplace or at school, but when it's with people we love, we just have the sense of immediacy that we need to get it out now. Instead of really taking a step back and saying, is when the car just broke down and she came home from work and the kids are screaming and the baby's hungry, is this the best time, to bring up this point about, whatever? No. So really getting people, and that in and of itself, just reminding them of tact and timing can create a little buffer between impulse to talk and actual verbalization that just allows a little bit more space and time and thinking so that what eventually comes out is actually more tactful and more effective. So, talking about guidelines for listening, how to listen when your partner has the speaker hat on. So first off, through your facial expressions, show that you accept, keyword, your partner's thoughts and feelings. That doesn't mean you agree with them. You just have to accept them. So if the patient is sitting there saying something and the partner is sitting there going, shaking the head, rolling the eyes, or trying to interrupt all the time, that's bad listening behavior, and we need to shape that. And as a couple therapist, you go in there, you stop it, and you say, what are you doing with your face right now? What do you think she's seeing when she's watching you listen to her? And then you get people to be able to start looking at what they're doing. Most of the time, people are completely unaware of the facial expressions that they're making. So you've got to get them in tune and have that meta-awareness of their own behavior so they know that just the expression changes that they're giving and the messages that they're giving back. And then, as a listener, we want you to look at the situation from your partner's perspective. So once again, this is creating meta in the relationship, getting the partner and the patient to be able to rise above their own perspective and really see the situation from the other side. Now, for our patients, when they're acutely underweight, and we know a subset of our patients have social cognitive deficits anyhow, this can be really tough. And so you sometimes need to do this in very limited amounts. And small successes are really worth celebrating. But it can be really hard for them when they're in the throes of anorexia to be able to step outside of their own perspective. Because one of the things that anorexia really does to you is it just puts your interpersonal blinders on. But in the moment, when you've got the partner in the room, it gives you a golden opportunity to help pull your patient's perspective out of that really self-absorbed perspective. And then after the speaker finishes speaking, we stop the speaker, we change hats, and it really is this mechanistic in the beginning until they get the hang of it. We put the hat on the listener, and we say, okay, now what I want you to do is summarize the most important feelings, desires, conflicts, and thoughts, and reflect back exactly what you just heard. Now, this can go back and forth several times. Sometimes they do a really nice job. Sometimes they selectively attend and will only pick up a small piece, but really miss what the core issue is. You do a little back and forth here. So you get the partner, whoever, you get the listener to reflect back, and then you ask the speaker, how'd he do? Or how did she do? Did the listener get the high points? Is there something that you really wanted to be heard that wasn't heard? Now, what happens then more often than not is the speaker tries to take it one step further and add another paragraph. And you need to rein them back in and say, no, we're just going back to that initial communication and making sure that what you said was listened to and reflected back accurately. We'll have another opportunity to go to another topic, but right now, this is the skill we're using. Now, this is a really different kind of therapy to do. How many people in here have done couple therapy ever? All right, there are a bunch of you, because I see some smiles going like, yeah, I know what this is like when you do this. But you really are, you're rolling up your sleeves, you're getting in there. You have to have a relationship with a couple so that you can really direct this conversation in an effective way. And so that they can trust you that you're using your cognitive behavioral couple therapy skills to improve their ability to communicate with each other. So after we get through a sharing thoughts and feelings exercise, we then go through this exercise that is more brainstorming. And this, for people who are decision-focused or very obsessional, for example, can be difficult because they don't like putting ideas on the table that are not tenable. They want to put solutions on the table that are workable, and we want them to go outside of that. We want them to be throwing every possible idea on the table, even if it's not going to work out in the long run. So all ideas are on the table, and most importantly, there's no judging. So when you're getting couples to brainstorm, if someone puts an outrageous comment on the table, the most likely knee-jerk response from the partner is, that's not going to work, or there's no way that's going to happen. You have to stifle that response and respond by saying, this is just brainstorming. We're getting all the ideas on the table now. That's all we want to do. No decisions are being made, but you're going from sensible ideas to crazy ideas. And I'm just thinking about this one example. So I'll throw an example in here about how a brainstorming worked. And this had to do with going to a family gathering for Thanksgiving. And for this patient, she was a woman, partner was a guy. It was the most high-risk time of the year. She started worrying about Thanksgiving dinner in August, knowing that this was coming. Which siblings were coming, which uncles were going to be there, who's cooking, what's going to be made, are there going to be vegetarian dishes, all this sort of thing. It was so difficult for her that in the past, she's had the equivalent of panic attacks at the dinner table and had to leave the dinner table, and then it created this huge family uproar because she thought everyone was looking at her, and of course everybody was looking at her, and was looking at her even more because she was having panic attacks at the Thanksgiving dinner table, and then it was like, it became a huge deal. What we were trying to figure out is how can she navigate Thanksgiving with her partner as a team months forward? How can they plan this out? We did the sharing thoughts and feeling things and started doing the brainstorming thing. examples of what were on the table. So one example is we don't go. And then they stay at home and they, get a chicken from, the Winn-Dixie or wherever you buy your food, Kroger's, and they just eat alone for Thanksgiving. Weren't allowed to judge, but that was on the table. She brings her own meal. She thought about bringing a little lunchbox for Thanksgiving just with her safe foods. That was on the table. Another thing was on the table was, I didn't judge, but sitting at the children's table. So they had an adult table and a children's table, and she goes, I'd actually feel a lot more comfortable if I could just sit with the kids. And brainstorming, I accepted it. And then there were some more perhaps doable ideas. And one of them she actually came up with was, how can I get him to help me more in the moment and be aware of what's going on with me? And what came out of that a little bit was he becomes less attentive to her and her anxiety when he drinks. And everybody at Thanksgiving drank wine. And he would just be sort of sitting there drinking his wine and eating his turkey, completely oblivious to the fact that she was basically panicking about having to eat in front of all these people. So she was like, well, what if we have him not drink at Thanksgiving dinner so that we can develop some signal whereby if I'm feeling like I'm about to really panic, we can just take a couple minutes and take a walk. And he can make the excuse for the family where I need to go outside for a minute. I was sitting there going, whoa, that's a really complicated but interesting and multifactorial, maybe too much to do. But with all that stuff on the table, they comfortably rejected the children's table. They comfortably rejected bringing her own little doggy bag thing. They totally rejected not going because that would have created more problem with the family anyhow. And so they decided as a couple that they wanted to focus on maybe actually making this thing work. And they did. And it was in some ways, having the contrast between the not so tenable ideas and the workable idea on the table was really helpful because they can see that these ones really aren't going to lead to a good outcome, but this one, there might be something there if we really work this through. And it was interesting because in the beginning, he wasn't too keen on not having wine with Thanksgiving dinner. But then when we realized that this was really his contribution to working together toward recovery from anorexia, he was like, maybe I can sacrifice that couple glasses of wine in order to get through this. She developed a signal that, just some little thing where she was going to tug her ear or something like that and elbow him if she needed to get out of there. And then she had a really good idea. She goes, my fear is that I'm going to do that, and he's going to be so in the situation, he's not going to see the signal. She goes, so I want a tier 2 signal, sort of yellow alert, orange alert, red alert, that I can really get his attention. And I'm like, this woman's really working it. She's really taken this idea, and she's in the situation. She knows what might happen, and she's coming up with contingencies. And then they came to a level 2 plan where, the tug was a little bit more dramatic and the elbow, whatever. But they tried it, and it worked. And he came to the party. He didn't have wine with dinner. She did. She panicked. And he came to the party and said, we need to take 5 minutes. We're going to head outside, and we'll be right back in. And he just took control of the situation. He took her arm. They went outside. They walked around the house. He got her breathing a little bit, got her centered. She came back in, finished the meal, and it was successful. And I was like, damn, that's cool when it works. But it's and it took both of them to do that and to come up with that solution. But that is how the brainstorming process works. Get rid of some of the less tenable options, find the one that is most likely to work, put it into play, and then bring it back in and do the debrief. So we went through every single step. And the big question was, why did he miss that first round signal, which he did miss? But part of it, this is a pretty gregarious guy. And he's with family, and they're talking sports, all that sort of stuff. And he just sort of missed it. But yet she wisely knew he might, came up with tier 2, and then it all worked out in the end. So that's the brainstorming process. All right, we're going to do one more of these sort of what's the couple thinking before we go from sharing thoughts and feelings to decision making. So let's start with the little couple down here. What you seeing? Leaning away. Yep. Embellish that a little bit.
They each have established a solid base on the opposite side of one another.
So they each have established a solid base on the opposite side of one another. So he's anchored here, and she's anchored there. Yep. What else do you see? Yep.
Looks like he's incredulous with what she is saying or something. Like he's saying, what are you saying?
Yeah.
What are you talking about?
So he's incredulous. He's like, say what? What's she talking about? Yep. What else? Anything else? Yeah?
She's looking at the therapist.
Okay, so you did the gaze lines. So she's looking at the therapist, he's looking at her. I see one more thing in here that I think is pretty important. Yeah.
She looks very comfortable with talking to the therapist. It's almost like she just wants to talk to the therapist.
She's creating a special space with the therapist, and he's not part of it. He's on the outside of that dyad. The other thing I see with her is she can't get further to the end of that couch. You know, I mean, she is wedged in there like yeah, not comfortable at all. Therapist, you can't really tell what the therapist is doing in that one. So anything else on that picture that anyone notices? Yeah.
The upper bodies are leaned out from one another.
Yep, same thing. You see that sort of like branching out that we didn't see in the couple with the cups when they were looking at each other. All right, how about these guys? What are they doing?
Sight lines looking at each other.
Okay, sight lines are looking at each other. Are the sight lines looking at each other directly? No. So if you trace where their eyes are going, they're looking at each other, but one of them's out of the side, so it's not completely direct. Okay, what else?
Her shoulders, like the one that's up is closer to him, and so it's like I can't tell from this angle, but like almost like a protective.
Right.
Not sure about what you're saying.
Yeah, so this shoulder is up. The one that's closest to him is sort of up, so it might be a little bit protective. All right?
The therapist is like pumped for this or something. And the hands there like something just said it wasn't so great.
Yeah, so the therapist is doing something, either stopping them, also look like she has flowers coming out of her head, which is kind of odd. But there's some traffic copping going on there for sure. What about their legs? Almost touching. Yeah. Why is she leaning forward? And does that say anything to you? There's something else going on in this couple that I don't completely understand. Is she wondering whether he might be defensive?
I don't think she wants him to have the upper hand, so she's leaning forward into him. She's not really very.
So it might be a power thing. So her leaning in might be a power thing. She doesn't want.
She's not leaning back and taking it.
She's really leaning in. Yeah. Yeah. I mean, a lot of this is sort of like a Rorschach, right? You know, I mean, we can project anything we want onto this. But yeah, one more.
Someone else actually said this, but they said it looks like a mother and a son, not a couple.
Ooh, he did something wrong.
Somebody said that, that's how it looks to me. Even just the way that, like maybe he's getting chastised.
Yeah. Yeah, that was my read of it originally, that she's got something, and I think that's related to the power question too. It's like she's got something on him, and the therapist is like, whoa, tone it down a little bit. But these are things, I mean, we have reviewed the tapes, we have reviewed all of these tapes, and the body language tells you as much as the words do. All right, what time do I go till, folks? Anybody know what the schedule is? I have another half an hour? All right, good. Okay, so when it comes then to decision making, this is when those decision makers get really happy because they can start actually making decisions. You have to state the issue clearly and specifically and phrase the issue in terms of behaviors. You do not want it to be some lofty, unexecutable thing that is just all thoughts and feelings, but not actually a behavior that we're going to do. And you break complex issues into several smaller issues and address one at a time. While you're doing it, you clarify why the issue is important and what your needs are. And here are some of the decision-making guidelines. So what you do is you propose solutions considering both people's preferences. And you go back to your brainstorming techniques, especially if you get stuck. If you don't feel like you're getting anywhere in decision-making, you've got to get it out there again to brainstorm. And then you adopt a solution that is agreeable to both of you. If you can't find a solution that pleases both partners, you suggest a compromise, and you state your solution in clear, specific behavioral terms. And this is very important. You decide on a trial period to implement the solution if it is something that comes up over and over again. So some people are concerned that once you determine what a solution is going to be in the therapy room, they're going to have to stick with that forever. I'm a huge believer in trying, tweaking, tweaking. You come up with a solution, you go back home, you try to put it into use, and if it doesn't work, you come back, you bring it back into the session, and you figure out how you can tweak your solution so it actually works for both of you. And this actually speaks to just that need for immediacy, that we really have to help people understand that human beings don't work that way. So people really like to have a solution that they go back and they implement it and it's all good. But we all know that that is just not the way human beings work. You go out, you try it, reality is a little different than you thought it might be in the therapy room, and what it actually is doing is that it's teaching people patience in change. You need to be patient when it comes to recovery from this disorder. And you need to not think that everything's going to come in big increments. So part of it is just getting them to see the parts of a solution that are effective and the parts that aren't so effective, and then working toward a more effective solution. And if I think about like the hundreds of years that I've been working in this field, and at baseline, I'm not like the most patient person in the world, but when it comes to treating anorexia nervosa, that's one framework where I know I have to be incredibly patient. And I think for both our patients and for their partners, this is one of the key lessons that they learn, especially the partners that have these expectations for quick outcome. So we spend a lot of time just talking about the basic communication skills because I think that's what you really need to know how to do before you even start tackling doing this work. But once you have those skills on board, then you can really build on them to help them address eating disorder-related behaviors. And you start working as a team to develop specific approaches to anorexia nervosa-related problem behaviors and situations. And not just dealing with the behaviors, but countering the avoidance of dealing with anorexia behaviors. And again, you're constantly personalizing the work to the patients in a couple of situations. So you need to identify the AN-specific issues. Is the patient restricting, binge eating, purging, excessive exercise? And interestingly, excessive exercise has been the hardest one that we've had to deal with. And for a couple reasons. One is because we have a lot of partners who are excessive exercisers as well. And there's a sort of some relationship bonding that goes on around the gym. And second, because so much of it can be done without the partner knowing about it. And it's tough. And build a shared understanding of anorexia and the impact it has on each partner in the relationship. And then you use those communication skills to develop constructive strategies for each of the behaviors. And this happens at about session 8 through 18. So some important things for the couple to address about food and eating, meal times and eating together as a couple and a family. We talked a little bit about that. And one of the things that has become very clear to me is that a lot of our couples, the patients completely hand over all food-related, like shopping, cooking, making of meals to the partner. That's happened probably in about 50% of our cases. And what this means is often the partners they have full-time jobs, they're doing all the food-related work, and they're dealing with a severely ill person in the family. So it ends up being a huge burden for them, in addition to all of the other caretaking that they're doing. And that gets into the food planning, purchase, and preparation. And so part of what we're doing in those situations is figuring out how gradually to start giving some of that responsibility back to the patient, step by step. All right. So we talked a lot about that. I want to go into the phase 3, which is the body image, physical affection, and sexuality-related issues. And here are, yeah, you can have some extra slides in there because we weren't able to do the audio, so apologies for that. So one of the hardest things for partners to understand is the body dissatisfaction and body distortion that they see. And when a patient says, "I'm fat," or "I hate my body," 10 times out of 10, the partner will counter with something like, "You're beautiful to me. You look great just the way you are. I think you look wonderful. You're not fat." The patient states their perception, the partner counters it with a "that's not true." And that never works. That falls flat on its face. Because no matter what the partner says, it's going to be perceived as, it'll be interpreted wrong. So what we work toward is we work toward the partner learning to agree to disagree regarding body image. And that's really hard, but it ends up being transformative. So what we ask them to say is we ask them to just say, "Look, what you see," and I'm going to use female here, "what you see is not what she sees. And your job is just to acknowledge that what she sees and what she experiences is different than what you see. I need you to just acknowledge but not agree." And then the goal is to have the patient express body image concerns with emotional support from the partner. What we do is, I don't think this is going to play, so I am going to exit. And a lot of you have probably seen this video, but we play this, don't go away, we play this for our partners so that they can see what body image is like. Here we go, I'll make it big. This is actually made by a Swedish support group. But nobody's seen that? Wow. So what we do is, okay, we can do this from current slide. We play that in the beginning of the session, and we have them share thoughts and feelings about it. And the partners invariably say, "Seriously? Is that what you see when you look in the mirror?" And the patients say, like, "Seriously, is that what you see when you look at me?" And it just creates this moment where it allows them to talk about the video, to apply it to themselves, and to acknowledge that their experience of the world on this parameter is completely different. And it's powerful. And this, you can get this on the web. And I use this for families too, just to help them understand what body image distortion is. Because I think for outside people who aren't in this field, it is the single hardest thing for people to grasp, that what you see is different than what they see. And the more we can illustrate it for them with concrete examples, the better it is. So we do that, and then we start moving into body image and the physical relationship. The physical relationship is often very disturbed. And the longer and more chronic the anorexia, often the worse it is. For the patient, their body dissatisfaction creates incredible discomfort with being touched or being seen at all. And sexual difficulties obviously also occur secondary to malnutrition, with libido just being squashed. And this creates, again, what often happens is the couple doesn't talk about it. So the sex life deteriorates, but there's no conversation in the couple about what's been going on. And they just drift farther and farther and farther apart. And most commonly, what you see is that there might be some touch that remains, but the minute the touch starts going in a direction that the patient fears, then there's complete pullback. The partners start feeling rejected. They wonder if there's something wrong with them. A lot of our partners, and you'll see this with Tommy, a lot of our partners who are overweight start being really afraid that the patient hates how they look, because they are precisely what the patient fears. And in fact, we've had a couple of really uncomfortable situations where the patient says, I think your weight is disgusting because you're exactly what I'm afraid of becoming. And that can kind of send shivers up and down your spine when you're in the therapy room for that kind of comment. But yet it opens up this whole layer of conversation where the partners then get to talk about their body image issues as well, many of whom have never had the opportunity to do so. So it ends up being a much more equal part of the therapy when you start hearing that the partners are suffering with their own concerns. So the partner might feel rejected when the patient withdraws physically. And we've also run into some really uncomfortable situations where the partner has started going elsewhere for sexual gratification because the patient has basically completely shut down that part of their relationship. But we ask, the couple identifies the way in which anorexia has impacted their physical relationship. As I mentioned, the couples vary widely, and we have to individualize the interventions for each couple. The goals are to enhance comfort, affection, and, if desired, the sexual relationship, using the skills that they learned in the first part of treatment. And we had this wonderful one video, because as I said, we video all the sessions, and the video keeps rolling, like if the therapist leaves the room or something like that. And so one of our therapists got paged out of a therapy session with one of the couples, and they were sitting in two chairs, sort of facing each other. Therapist got called out, video was still rolling, and this was sort of like 2/3 of the way through UCAN. And then all of a sudden, like, you saw the patient sort of like looking around, like the camera's on, and then she like jumped over and she just sat really briefly on her partner's lap, gave him a little hug, and they cuddled for a couple minutes, and then she was like, oh God, the therapist is gonna come back, and she jumped back into her chair. But we were able to see that on the supervision tapes, and it was just a moment, and these guys hadn't touched. They hadn't touched for years. And it was just this little moment of sweetness that we were privileged enough to be able to see because the cameras were still rolling. But it was just such a neat sign that we were on the right track. And she was still afraid that, if they did that he would want to take it one step further. But he had learned that, he needs to just be very careful to not give signals, to not think that just because she's sitting on your lap, she doesn't want to, have sex right now. So he was able to put the brakes on, and she was able to reach out and actually do that and feel comfortable with it. It was cute. And then when we bring the treatment to a close, we continue to address what the status of both the anorexia and the relationship is. We focus on classic relapse prevention strategies, and we look at classic CBT, high-risk situations, and addressing slips and relapses, both for the eating disorder and for the couple. And then we just do general planning for the future and increasing positives in their relationship. And this really ends up being a major focus of the last several sessions, because for so many of them, their relationship has revolved around anorexia nervosa, sometimes for years. And it really is how to bring more positive things back into their relationship, things that they can do together that are not eating related, that are not food related, that really help them, again, rebuild a relationship that has centered around an eating disorder for often a very long period of time. We say farewell. It's about a 22 to 24 session program, and that's too short. We need a UCAN 2. because what we often find is that this gets them to a point where they're really doing some awesome couple work together, and we can see how just another layer would just bring them to a completely different plane as a couple. And the other thing that happens is you start seeing it for those ones who have kids, that the skills generalizing to their parenting. So one of our couples had a little boy who had ADHD, and he was seen in the same clinic, near the eating disorders program. And they brought the kid in for one of his ADHD appointments, and the kid was like being really loud and rowdy, and wanted to do something. And the mom, who had been through UCAN, said, "Honey, we're not decision making now. We're just sharing thoughts and feelings." I was like, boom, yes, we got that. So that's pretty much the anorexia piece. And of course, we could spend a week going through how to do this treatment. But I wanted to spend a couple minutes talking about the adaptations that we made for BED, and then show you a video of Margie and Tommy talking about their experience with UCAN together. The reason we moved on to BED from anorexia is because there's such a need. We have so many couples in which either one or both partners has BED. And the frequency with which we're seeing both partners having BED is really high. And what we're seeing in those couples is actually food being the bond in their relationship. So for a lot of them, a lot of the ones in which, who are also having problems with affection and sexuality, food has almost become their sex. So they'll sit down and they'll binge on really tasty high-risk foods together. And they look forward to that, and it's highly reinforcing. And that becomes a tough cycle to break, because that's become sort of like the anchor for the pleasure in their relationship. And I said that first because that's one of the toughest things that you're going to encounter when you start doing this work with binge eating disorder. And thanks to GFED for supporting this work. I'm trying to figure out, we don't have that much time, and I want to leave time for questions. So I want to talk a little bit about some of the work that we've done in BED and what we're seeing. So in the individual who has BED, we're seeing a lot of secrecy, a lot of minimization and shame, a lot of isolation, a desperate desire for the partner to understand, and a desire to feel accepted, not just with the eating disorder, but for those patients who are overweight, also in terms of their physical appearance. Partners who don't have BED themselves are often unaware that the patient is suffering. They're unsure or avoidant. They go through periods of being the food police. They may criticize or simplify what the patient's going through, but at the bottom of it all, they have a sense of helplessness, guilt, fear, and frustration. For both anorexia and binge eating disorder, these partners desperately want to help. They so want to be able to help, but they've got no playbook. There are no guidelines for how to help a partner who has an eating disorder. The couple, as a couple, they want to talk about it, but they don't know how. It ends up being a situation that they just avoid. They just stop talking about food. It is the elephant in the room for them. They can get into attack mode, they can criticize, and they can be negative, but what they want more than anything is they want to be able to provide support. And here's a quote from a patient. It really was not something we talked about at all. Basically, I was completely alone with my eating disorder because I didn't talk about it. I was very ashamed because of the amount of binging that I was doing. I thought it was my problem. I was weak, and I just needed to learn some self-discipline. Again, that sense that this is all about willpower, which it isn't. From a partner, it seems like whenever I talk to her about weight or her eating, it upsets her. And I know that when she's upset, she eats more. So I don't see that it would really be productive. In general, I try to stay away from the subject because I feel that it would be putting pressure on her, and that would cause her to eat more. So you can see how this cycle just continues, and it just promotes this pattern of avoidance. Believe it or not, we just had a huge blowout yesterday morning over soda. It was pretty awful. He wanted me to get soda, and I told him no, because I was like, it's really difficult for me not to drink a lot of soda when it's in the house. And his response immediately, because he was upset about it, was, well, I have to suffer because you can't control yourself. So these are some of the prejudices that are coming into the room. The Unite flow is very much like the UCAN flow with some really important differences. So we start out the same way with the introduction and the relationship assessment, dealing with the communication skills. But then we start looking at normalizing eating and addressing specific challenges that BED poses, some of which are similar, some of which are different. But where things change are looking at body image and weight stigma, weight or health concerns, and then getting into the same physical affection and sexuality. And here's what's happening here. So we had a number of couples in our formative pilot work in which the partner had lost interest in the patient because she or he had gained weight. And underneath that were all sort of weight stigma related biases. So we realized that we need to do a special module all on weight stigma. We need to educate partners of what it's like to be a person in a larger body, going around, being discriminated against, and in these situations, being rejected on your physical appearance by your partner. This has been hard, and it's really interesting. And this might just be part of being in the South, but we had a lot of partners who came in who said, I expect my wife to show well. And I was like, whew, neat air. But I know.
It's like a kennel club.
Well, exactly. But they were like, she didn't look like this. Well, oh my God, I'm being videotaped too. Do not show this in the South. I will be like tarred and feathered. But they were like, you know, I married her in part because she was such an attractive woman. And now I feel uncomfortable taking her out in public because she's so big. And right then and there, I'm like, oh my God, I got a lot of work to do with this couple. But we had to really develop a module to help train partners and patients to pull back from that intense appearance focus to appreciate the impact that weight stigma and discrimination has on binge eating disorder, and to get these guys out of this mindset that their wife has to show well. And that's pretty tough. It's really tough work. And I honest to God didn't realize that this mentality is as widespread as it is, and I don't think it's just in the South. So once you start getting in there and talking to partners about how they feel about changes in the patient's physical appearance, you get into some kind of ugly territory. And it's tough work, and you have to be really mindful of your own feelings about weight, because therapists who aren't square with that are going to step right into it. So I recommend not just doing couple therapy with BED, but if you're working with BED at all, do some of your own work. Find out what your prejudices are, and when you're walking somewhere and you're behind someone who's large, or if you see someone who's large, pay attention to what goes on in your head, because I think, I'm getting a little preachy right now, but I feel really seriously about this, because so many people in this field have prejudices against large people. Yeah?
In those situations, are the partners actually attracted to the spouse, but then they're ashamed that other people don't see them as attractive?
No. The partners have lost their attraction based on their prejudices about what's attractive, and attractive is only thin. So we sort of have to reteach them about what it means to be attracted to someone. Yeah?
About the other way, where the patient starts doing defined binge eating.
Yes.
And I'll show you.
Absolutely. In fact, this is a really interesting part of binge eating disorder. I wish I had this here, but I had to do sort of a psychological profile of what the psychology of someone with binge eating disorder is. And that's actually a really important piece. That people who had the disorder said, yeah, this is really what it is. So if there's just that defiant little piece that is like, I'll show you, I'll binge even more. And it's self-destructive in that it continues the cycle, but at the same time, and this is one of the emotions that I think we under-recognize as being something that fuels binge eating disorder, and that's anger. Because there's actually a lot of anger about, especially people who are overweight, about the discrimination that they felt, about all the people who have said if you just go on a diet or if you just control yourself, you'll be fine. There's some real anger in there that just continues to fuel the disorder. And unless you tap into that, both in an individual therapy and in couple therapy, you're going to miss a really important piece that can fuel relapse. So that's a really important point. I am so off the track right now, but I think this is actually, I actually think this is really important to deal with. Yeah.
When you talk about anorexia, the biological component, and in working with binge eating disorder patients, I think of the biological component that can often be resolved with a gastric bypass, where that actually changes the biology of the appetite, satiety, and the hunger. And so isn't that an important factor?
We do have a bariatric surgery module, but unfortunately, for people with binge eating disorder who have bariatric surgery, for some of them, it does lead to a decrease in binge eating. To others, unfortunately, it doesn't. And part of our job is actually to figure out who's who. Can we predict for whom it's going to be a good outcome, and can we predict the people for whom it's actually going to be risky because they'll continue to binge after bariatric surgery, and that can be pretty nasty physically. We've had a couple couples who have come through, who have gone through bariatric surgery, and talk about that, because it actually bariatric surgery has a huge impact on partners and families, because you see the entire food environment in the house shift before and afterwards. So it's actually quite interesting to see just how the whole family changes in response to one person getting bariatric surgery. Yeah. I could just take questions for the remaining time if we want to do it. Yeah.
I just wanted to add that I think that binge eating with couples with two people from different ethnicities or different countries, I mean, it's very complicated. Someone's American and someone's from Europe, for example. Right. I mean, it can be very strong bias in weight and how we eat here.
Yes. The comment, an important one, is when you're dealing with couples from different ethnicities or ancestries or countries. One of the videos I was going to show you was a French-South African couple who come from completely different food traditions. We actually have a separate study that is just for Latinos. And we've had to sort of change that. We started out having it just be couple therapy for Latinos, but then we found out, especially in the North Carolina Latino community, which is really quite large, that the partner wasn't always the person that people wanted to bring in for therapy. So we had a lot of situations where it was a sister or a mother, and we had to completely morph the intervention to match the ethnicity, which was an unexpected outcome, but a very important one. But in a lot of situations, there were a couple. I mean, there were immigration issues where the partner wasn't there, but there were also situations where the partner just would not come in. But yet they needed to have a support person in the room in order to have someone to work with them toward recovery. But yes, it gets very. But even if it's not ethnicities, we all come from different food cultures. All of our families deal with food really differently, and you have no idea until you start doing these sorts of focus groups and couple interviews, just how much food baggage we all bring with us into a relationship. And I think that the really simple way of looking at it is what you eat for Thanksgiving. And if you actually trace that through your family legacy, I know where every single recipe came from, which came from my side of the family, which came from his side of the family, which came from my maternal grandmother, and it's and these things get filtered down, and that's part of our family food legacy. But part of the richness of that gets lost in these couples because it's such an uncomfortable issue. And it's fun to see that coming back in as they get well enough to figure out how they can sort of redevelop their relationships with their family food legacies. Yeah. Yeah.
About how
go figure. People want this. I mean, people want this. It's like, I want to bring him in. I want him to understand it. I think that's the pivot point, is that they want someone to understand. Of course, there are always the hesitations and the ambivalence about getting well and the fear about getting well. But what actually happens, and one of the things that we see in the data is our dropout is so much lower than for individual clinical trials. And I think what's going on there, and we start seeing like these feelings of dropout right as we're approaching the body image and sexuality section. They're starting to like, no, I don't think I can do this. But the partners are saying, you've dragged me to how many of these sessions? We are not quitting now. And so they're actually the reason why we're not getting dropout. And they'll come in and say it, and they're like, she didn't want to come today, but we're here. We're going to be here next week. So I think that's actually, and we can't treat people if they don't come in. So I think once they're in, the partners play a huge role in keeping them in treatment and getting them back if they start slipping or relapsing again. Yeah.
Can you say a little bit about the severity of the illness for both the anorexia and the PhD treatment at the start and then where people are?
Yeah. Yeah. So the people that we took into the original UCAN clinical trial really varied in terms of how severely ill they were in the beginning. So some people had just undergone like the first phase of refeeding in hospital. Some people were really severe and enduring anorexia nervosa. So we really had a range of severity. We got more weight gain in our initial clinical trial than any published clinical trial. And that was sort of surprising. But again, I think it's because the partners were there supporting it. We're in follow-up phases now. We're doing a second clinical trial now to see if that fits, but we're still seeing the same thing. And I think it's a lot easier for people to recover if they've got a teammate. I think that's what it's really all about. And again, it's not magic, but it is stronger than what we see in individual trials. And for binge eating disorder, we don't have outcome yet. So this is like brand new, hot off the press. We're running our first patients through now. And we're going to see how this whole weight stigma stuff goes over. And we're going to have to do a little tweaking, I think, to see how receptive it is. So I don't know what the severity is going to be like afterwards, but we're aiming for abstinence. Because from my perspective, abstinence from binge eating is really important for binge eating disorder treatment. Because even if a couple binges are left over, that still keeps that door open for additional binges. Yeah.
So when you're talking about the partner who wants the wife or other partners to show well,
Yeah.
how do you kind of finding myself? How do you get into that zone where now you have a supportive partner?
Yeah.
And how do you coach your therapist to manage their anger?
Right. Yeah, no, excellent question. So when you have one of these partners who wants their partner to show well, how do you get into the zone where they can be supportive, and how do you get the therapist to deal with their anger? The angle that we're actually taking is focusing on weight loss not being a targeted outcome for this treatment. Because what they're saying, what the partners are really saying is, can you please help her lose weight? And that's their expectation when they come in. And we clarify that so many times in the past, people have told her or him to lose weight, and that has just further perpetuated the disorder. Our job is to get the binge eating under control, and then perhaps the weight can be a goal in the future, but that's to be discussed later. And so we harp in the very beginning on the fact that this is not a weight loss treatment. This person has an eating disorder, and we need to get the eating under control, and the comorbid anxiety and depression. The partners will often come back and say things like, well, she has high blood pressure and her cholesterol is high, and don't we need to get that weight down? So then they back off from the show, and they focus more on the, but. And we're like, yeah, guess what? But if we get this binge eating under control, you're going to start seeing changes in those numbers. We're going to start seeing the hypertension go down. We're going to start seeing this go down. And we might see a little bit of weight loss, but that is not our focus. So work with us here. You're here for the treatment of binge eating disorder. You are not here for a weight loss program. And then we talk about their feelings about that. And that's the hook that we use to bring them in. We'll see. how it goes. It's hard. And it's hard for patients, too, because patients often come in with those dual expectations. I want you to take my binge eating away, and I want to lose weight. And so we actually have to educate them that, we're not going to really target both of those things at the same time. My job is to get your binge eating under control first. Yeah.
So my job is to keep us on schedule. So if you need a few more minutes to finish up, or
There's a desperate question. Okay.
So how can this be adapted to working with adolescents? Because it's a great concept, obviously, and it works really well also with addiction
Right.
substances. So how would you do this, and some of the family members around these issues might not be the best partners, or would they be the best partners to these psychoed or whatever?
So the question is, how can we adapt this for adolescents? The binge eating disorder piece, or the for both? Well, I think we do have it. We have family-based therapy for anorexia because we sort of developed this because that existed. We figure, like, how can we give to adults what we already have for adolescents? And I think they're doing a lot of good work now, sort of saying, until what age will this family-based treatment thing work? Because we see a lot of these people who cross the magical 18-year-old barrier who still desperately need family-based therapy. And again, bring the family members in. We've got some stuff starting to see whether you can actually do this with friends and peers, but it's a huge responsibility, and that's kind of tough, so we're not 100% sure that that's going to be a good angle. Or a trusted adult, and I think that's what we're seeing in the Latino study, where we have the person nominate who's the best person, who do you want, and sometimes it isn't a family member, sometimes it is a good friend, and that model might be generalizable to other situations. Yeah.
I just want to ask you if you comment on the previous same-sex couples.
Yeah. Yeah, no, I've tried to clarify that this goes in both directions, and we've had both. Yeah. And that's been, well, with same-sex couples and also like males with eating disorders and female partners. So this is absolutely morphable in any direction. The majority of people that we've had have been female patients with anorexia with male partners. But that's probably just demographic. But it cuts across, it works really well in all situations. And it's actually been very interesting working with male patients with female partners and male patients with male partners. The situations are very much the same, but then the whole sort of like double stigma issue comes in often when we had to deal with, is your eating disorder in any way related to any of the complexities that you have as a homosexual couple? And for some it is, for some it isn't. And then we had one same-sex female couple where both of them had anorexia. That was really tough. That's really tough. And then you start getting into this almost like, there's almost like there's a competitive component of it. And looking at each other's bodies and comparing each other's bodies, and that's another talk. It is. It really is about how to, because that increases the level of complexity beyond standard couple therapy. Yep. That was 2.
Thank you very much.